Good morning and welcome again to the next series of acid-base balance and probably a primer to analysis of blood gas. Now most of the slides are available in Painfree Partha.com. So this is our institute, Mahatma Gandhi Medical College and Research Institute, and our director of seed dreams and the legendary teacher of 2 centuries, Professor Ravi Shankar. What is the normal pH? Now you see the normal pH is 7.36 to 7.44. Now the less than 7.35 is acidosis and more than 7.45 is alkalosis. Already I have told in my last slide, the process is called acidosis and the result is called acidemia. Diabetic ketoacidosis is a process. Blood becomes acidemic. Sometimes compensatory mechanisms exist and the blood does not become acidic much, but DKA persists. The ketoacidosis, the process persists. What are the basic types? One is acidosis, another is alkalosis. Another is metabolic acidosis and metabolic alkalosis, respiratory acidosis and respiratory alkalosis. It may be an acute metabolic acidosis or a chronic metabolic alkalosis. Similarly, respiratory. These are all the basic types. Acidosis, alkalosis, metabolic, respiratory, acute or chronic. This is what is the basic types of acid-base imbalance. Now, what is metabolic and what is respiratory? Very simple. Acidosis occurs when the lungs fail to remove excess carbon dioxide from our bloodstream during the process of respiration. So we are not able to exhale carbon dioxide. Carbon dioxide is getting accumulated. That is an acid. That is a respiratory acidosis. An acidosis that occurs when the digestive and urinary systems break out. There is a failure of urinary system. They cannot let out all bicarb or something like that. Acidosis is going on. Hydrogen ion is accumulating. That is called metabolic. So it's a non-respiratory component. Respiratory alkalosis is a disturbance in acid-base balance due to alveolar hyperventilation. We ventilate, wash out carbon dioxide. We develop an alkalosis, that is respiratory alkalosis. Metabolic alkalosis is a non-respiratory acid exhaust. So carbon dioxide is not going out, but HCl is going out. For example, if the patient vomits, he throws out the acids. So that is metabolic alkalosis. So respiratory acidosis and alkalosis. Below 7.35, above 7.45. It may be a respiratory cause or a metabolic cause. Now you see already metabolic acidosis means what? Hydrogen ion is accumulating because of something else. For example, renal failure. For example, something called diabetes mellitus ketoacidosis. So the bicarb is decreased. In respiratory alkalosis, the carbon dioxide is decreased. In respiratory acidosis, the PCO2 is raised. In metabolic alkalosis, this is bicarb is increased. So this is the primary problem. Metabolic acidosis na bicarb is less, pH is less. Respiratory alkalosis na PCO2 is less and pH is high. Respiratory acidosis, pH is low. But because of what? Carbon dioxide retention. This is what is the primary problem and each of these things. Now, if there is a compensation, for example, a metabolic alkalosis, PCO2 will rise. A metabolic acidosis, we will try to wash out the carbon dioxide and maintain pH. These are all the compensations. A metabolic will get a respiratory compensation, a respiratory will get a metabolic compensation in the reverse way. Now, this is an excellent graph to know because now you see acute respiratory acidosis. What is the acute respiratory acidosis? Patient is having bronchial asthma or something like that. Now, carbon dioxide, this is the carbon dioxide curve. This is the blood pH. This is the bicarb and this is the hydrogen ion concentration. Normal is around 40. Now this is a normal 40. Okay, now you see an acute respiratory acidosis. pH has come down to 7.2 because it's an acidosis. It is acute. There is no compensations. There is no compensations. There is metabolic compensation erpate. The pH is not shifting up. Here you can see acute respiratory acidosis. Where is the PCO2 curve? PCO2 curve is around 90. The pH is less. The hydrogen ion concentration is arterial bicarb. See here, not much of change. It's around 28. But in chronic respiratory acidosis, the bicarb rises and the pH comes to normal, even though the PCO2 is. Again, I will go again. An acute respiratory acidosis. This is a PCO2 curve. PCO2 curve is around 90. Acidosis 7.1. Now we see the bicarb is around 24 because there is no metabolic compensation. Now there is a metabolic compensation. The bicarb is high, the pH is raised, still the PCO2 is high. PCO2 is high, there is respiratory acidosis because there is a compensation. This is what is called a chronic respiratory acidosis. Respiratory acidosis is a phenomenon, process, but pH is almost normal. This is what is metabolic acidosis if you take. Now, for example, a renal failure or a diabetic ketoacidosis. This pH is come down. Bicarb is coming down from 24 to 8. PCO2 is also on the range here around 10 or 25 or something like that. But if you go to chronic metabolic, PCO2 slowly changes to get the pH up. So this is what is the acute metabolic acidosis. Now we will go to acute respiratory acidosis. CNS lesions, sedatives, sometimes pulmonary pneumothorax collapse, so many causes. So compensations comes last. Here is the acute respiratory acidosis. Now I have already told chronic respiratory acidosis. pH remains normal. PCO2 is high. See, bicarb is high. pH is normal. Now this is respiratory alkalosis. The picture is here. pH is raised. The PCO2 is low. And patient is developing respiratory alkalosis because of this hyperventilation. Sometimes there may be psychogenic hyperventilation, sometimes hypoxia-induced pulmonary edema, induced hypoxia. The patient tries to hyperventilate and throws out the carbon dioxide, resulting in respiratory alkalosis. These are all the causes of respiratory alkalosis. An acute metabolic acidosis, I'm not going into the details because I'm into the concept and not into the listing of causes. Again, you see metabolic acidosis, which I have already told and described. This is a metabolic alkalosis. pH is high. Metabolic cause, because we are throwing out, vomiting, hydrogen ion is thrown out. The hydrogen ion has come from 40 to 30 or 25. The PCO2, here you can see, slightly building up. Now we will go to important clinical terms. What is base excess and what is base deficit? Base excess is the amount of strong acid that needs to be added in vitro to 1 liter of fully oxygenated blood in order to return to normal conditions. Okay, now there is some alkalosis. If you want to retain this, you put some acid into this. How much acid is needed? That is what is base excess. Base deficit occurs in acidosis. Base excess occurs in alkalosis. In base excess, we need to add acid to find out how much is needed to get the pH at PCO2 of 40 at temperature of 77. These are all standardized. So when PCO2 is standardized, temperature is standardized, pH is standardized, you need how much alkali to be added, how much alkali, strong alkali to be added. That means it is going towards a metabolic cause. So for example, the base deficit is high and there is an acidosis. This seems to be going in favor of a metabolic acidosis because we have told that we are going to add a strong alkali, but PCO2 is 40 only. We are titrating it to a PCO2 of 40. That is why when the base deficit is high, you are likely to be in favor of a metabolic acidosis. What is base excess and base deficit? Actual and standard base excess. When the hemoglobin is 5, the letter gives a better value of the base excess of the entire ECF. So there is a small difference. Is hemoglobin is 5 means it correlates with ECF. Standard base excess. This is almost similar, indicates a metabolic problem. I'm again telling you, when the bicarb, pH, PCO2 all are standardized, probably a metabolic reason. There's one more term called standard bicarbonate. It is a concentration of bicarbonate in the plasma from blood, which is equilibrated with a normal PCO2 and a normal PO2. Now you see, now bicarb is 16 or 18. There is a move towards acidosis. And standard bicarb is also 18. Means now we have calibrated the blood to a PCO2 of 40. It is not 28. So 40. Then still the bicarb is 80, means the component is metabolic. We have thrown out the respiratory component. These were all the things which were there in the 1990s. Base excess, base deficit, standard bicarb towards metabolic acidosis. Standard bicarb is low, metabolic. Standard bicarb is something, there is a respiratory component. So that is what was taught long back. Now, what was the problems of these things? Inaccurate identification of severity. How much severe it is difficult. What is acute versus chronic? Can we estimate? How was the profile of the metabolic disturbance? Difficult. Mixed acid-base disturbance, very difficult. For example, an acidosis with a metabolic alkalosis and metabolic acidosis with an individual separate respiratory alkalosis. All these things cannot be identified with the so-called base excess and standard bicarb. So all these things were a problem. So we came out with lot of terms, and I will explain one to one in simple terms. Now, what is anion gap? Anion gap is sodium plus potassium. What is sodium plus potassium? 135 plus 5, 140. Chloride plus bicarb. What is that? 130. This is around 105. This is around 25. This is 130. This is normally 10. 8 to 11 is normal. So we are measuring sodium and measuring potassium. We are measuring chloride and we are measuring bicarb. So this is the difference between measured cations and measured anions. Measured cations is 140, measured anions is 130. So there is a difference of 10. This is what is called unmeasured anions. We are electrically neutral. We are not having high anions. So we are having unmeasured anions. These unmeasured anions is normally 8 to 11, and this is called the anion gap. Sodium plus potassium minus chloride plus bicarb is normally around 8 to 11. This is called the anion gap. Now you see sodium plus potassium. This is chloride plus bicarb. Now you see we have to have 140 here also. This is the 10. This is measured by some sort of salicylates, formates, sulfates. Normally these things is unmeasured phosphates, unmeasured sulfates. Something can contribute this. If this is high, then there is danger because salicylate is increased, lactate is increasing. Two types of metabolic acidosis: normal anion gap and increased anion gap. Now what we have told, sodium plus potassium minus chloride plus bicarb. Chloride plus bicarb is decreased now, anion gap will increase. Now 140 minus 120, 20. So there's anion gap is increased. Now we have an acidosis, but we have a normal anion gap because whatever hydrogen is lost, chloride is getting retained. So the anion gap remains normal as 110. This is called normal anion gap acidosis. I will come back again with clear definitions. Gold mark. See, I'm not going to again details. Lactic for renal failure, diabetic acidosis, and lactic acidosis. These are all the three clinically important things. Lactate, renal failure, and ketones. They are increased anion gap metabolic acidosis. See the unmeasured anions, because of these all these things, anions will get increased. So acidosis followed by increased anion gap. Probably we are in for decay, salicylate. No, TKA, lactate, and renal failure. These are the three common things. Now we have already told sodium plus potassium minus. Now you see bicarb is decreased because metabolic acidosis. Automatically the gap widens to 22. Here it is 140. This 25 becomes 12. 12 plus 90, the gap becomes high. There is no increase in chloride. You see here, acidosis, bicarb decreases. Now anion gap is what? This is the anion gap. Very clear. There is one more term is going to come. That is strong ion difference, where bicarb will not be there. Strong ion difference of bicarb will not be there. So this is anion gap. Sodium plus potassium minus bicarb plus chloride. This comes down in acidosis. So there is a gap. This is what is called increased anion gap. Now we have a metabolic acidosis where there is a chloride retention. For example, in hyperchloremic metabolic acidosis, this is normal anion. Chloride increases. Nagma, what I call as hard up. Ureterosigmoid fistula, pancreatic fistula, sometimes acetozolamide use, sometimes RTAs, renal tubular acidosis, normal anion gap because we are retaining some sort of chloride. This is normal anion gap metabolic acidosis, NAGMA. HCO3 decreases, but chloride increases. Now you see the anion gap is similar, normal 8 to 11, but there is a metabolic acidosis. Ammonium chloride ingestion. Acidosis is there because bicarb decreases, but chloride causes chlorine to increase, so NAGMA. Renal tubular acidosis. Loss of bicarbonate is there, but it produces volume contraction. So the kidneys retain chloride. So bicarb is lost, kidneys are retain chloride. So this is adjusted to keep the anion gap between 8 to 11. Sodium chloride administration, very simple. Acidosis with chloride ions, NAGMA. Now what are the clinical uses of anion? Now we have found out anion gap, high, normal, clinical as metabolic acidosis. Yes, we know that this elevated anion gap must be caused by all these things: renal failure, uremia, ketosis, methanol poisoning, ulcers. Low anion gaps values are rare, but may also be seen with hypoalbuminemia and hypercalcemia because of increased unmeasured cations. Now we have anion gap is about unmeasured anions. Now, if we have got unmeasured cations, so the anion gap changes. It is rare, severe hypercalcemia. These are all some of the gaps in the anion gap. The serum chloride concentration is raised approximately by 3 for every bromide. Lithium, hypercalcium, all these things may change your approach to your anion gap. So all these things beware. Yes. Don't worry. Only 2 more terms are there. Already there is a confusion. What is strong ion difference? Is the difference between simply sodium minus chloride. Sodium is 140, chloride is 140. But if you add calcium and magnesium this side and with lactate on the other side, it may be around 40. This is what is the strong ion difference. What is the strong ion in the plasma? Sodium is a strong cation, chloride is a strong ion. What is the difference? This is around 40. Chloride, sodium is around 135 to 140. This is around 100. So it is around 40. So changes in strong ion difference. What is strong ion difference? Sodium minus chloride. What is normal? 40. Now if you have a dehydration, concentrations of the alkali, your sodium will change, or overhydration, dilutional acidosis. This will cause strong ions to change. And decreased sodium acidosis. And increased sodium, increased acidity and alkalosis. So increased chloride. So we can have an idea about what is happening to the sodium and what is happening to the acidosis by finding out the strong ion difference. Now we know what is strong ion difference. Dehydration, concentration can cause changes in strong ions. What is delta gap? Now we know what is anion gap. What is the anion gap of normal 8 to 11, 10 or 12, 11 or 12? The coexistence of two metabolic acid base may be delta gap is equal to anion gap minus 12 and delta gap plus bicarb is equal to 22 plus 26. The normal. If there is a more increase, there is an additional metabolic alkalosis. If it is less than 22, there is a metabolic acidosis. Now we have a metabolic acidosis. Okay, this is the increased anion gap acidosis. What we have now? Increased anion gap metabolic acidosis. Anion gap is 22 or something like that. Now we have an acidosis. Now sodium chloride acidosis. Anion gap is equal to 29 for this patient. But normally what is that? 12. So delta gap is equal to 17. We have a bicarb of 50 because it is an acidosis. Now we have a renal tubular acidosis. Whatever it is, now leave it. Acute uremia, acidosis. We are having this 15 as bicarb. And all these things. Now anion gap is equal to 145, 105 plus 15 bicarb is 29. Delta gap in what we have found in the patient, that is 29. What is normal? That is 17. In the 17 plus bicarb is equal to 32. So that is, if it is more than 26, there is an additional metabolic alkalosis. That is what is needed. So what is what? So delta gap is less than 22 or more than 26. Additional metabolic acidosis additional metabolic alkalosis. This is what we are going to find out from a delta gap. What is delta gap? Normal anion gap has to be subtracted from the patient's anion gap. This value will be 12 or 13. You add up bicarb. 12 or 13 plus bicarb is 13 or 14 means it is only 22 or something like that. So it's normal. If it is going to be high 29, bicarb is high, but still there is an additional metabolic alkalosis rather than your uremic increased anion gap acidosis. Understand? Now we will go to Winter's formula for metabolic acidosis compensation. Now we have metabolic acidosis. For example, a diabetic ketosis, acidosis. We breathe, wash out carbon dioxide, get the pH down. Whatever it is, uremic acidosis, slightly wash out carbon dioxide and get the pH. How far it can compensate? How much it can compensate? What now the pH is 7.2. What should be the expected PCO2? More than that, there is some other problem. Now we have a pH of 7.2 because of the diabetic ketoacidosis. What should be the PaCO2 for this as a compensation? Now you see 1.5 plus bicarb plus 8. If a PaCO2 is lower than this, then there is a concomitant respiratory alkalosis. If the PCO2 is higher, there is a concomitant respiratory acidosis. Now again, I am going now. Metabolic acidosis situation. pH is 7.3. Now what we have is 1.5 into bicarb is plus 8. 1.5 into 15 is 22.5. Plus 8 is around 31. PCO2 is 32. There is no primary respiratory problem. The metabolic acidosis. Because the expected PCO2 is falling a line for this pH. Because of the uremic acidosis, the PCO2 has come down from 38 to 32. This is normal. If it comes down to 26, then there is a primary respiratory alkalosis. Something is washing out carbon dioxide. If it is more than this, there is a primary other problem with respiration. Understand or not? You have to have a PCO2 for this pH difference, this much only. If that comes down more, then we think that's a primary respiratory alkalosis which is washing out rather than a metabolic acidosis. Now this is anion gap, sodium plus potassium minus chloride plus. This is delta gap, anion gap minus baseline gap. There is also something called delta bicarb, 25 minus bicarb. Delta gradient is delta gap minus delta bicarb. There are so many things like this. Delta ratio. See, for example, this delta ratio, anion gap bicarb 0.4 due to a pure non-ion gap. 0.4 mixed ion and anion. 0.8 to 2 pure. This is what we should know, the delta ratio like this. Now, what is the delta ratio? Already in the previous slide I have shown. If this delta ratio is different, we are having mixed acid base problems. Now we have what is acidosis and what is acidemia. What are the types? Respiratory and metabolic, acute and chronic. Acidemia is acid and acidosis is the process. What are the causes of metabolic acidosis and respiratory acidosis? There's metabolic and respiratory alkalosis. What are the compensations? What is anion gap and what is delta gap? What is base excess? What is SID? What is standard bicarb? What is the normal PCO2? If the PCO2 is not 1.5 into bicarb plus 8, then there is some problem. There is an extra respiratory alkalosis.